Good evening to all. I am Dr. Ajay, Assistant Professor, Karpaga Vinayaga Institute of Medical Sciences, and I thank Medusane for giving me this opportunity to take a class for a pre-final students in their group. And I have been in this teaching field for the past 4 years. I have been taking entrance coaching classes in various institutes, and I have been taking classes for the pre-final students in my institute. So today we will have a discussion on a topic which is which is a easy one, but it is a bit confusing also, and it is one important essay topic for you also. The topic of allergic rhinitis. Allergic rhinitis is a very simple one, so just go ahead with the topic. So, what is allergic rhinitis? Allergic rhinitis, as the name indicates, allergic rhinitis is nothing but it is a IgE mediated. 1 minute. It is a IgE, immunoglobulin E. In your pathology you would have come across the various hypersensitivity reaction, right? So it is a IgE mediated immunological response to some aeroallergens, some nasal allergens, right? Some allergens in our nasal mucosa. This is allergic rhinitis. So it is a IgE mediated immunological response to allergens in our nasal mucosa is allergic rhinitis. Okay. So what happens with allergic rhinitis? What are the so we come across lot of patients, even we have allergic rhinitis. Do we sneeze? Yes, we sneeze. We have allergic rhinitis. We have allergy to various substances. So what are the characteristic features, or what are the cardinal symptoms in allergic rhinitis? The cardinal symptoms will be the patients will have severe rhinorrhea. That is, rhinorrhea is nothing but a nasal discharge. Okay, the patient will say there is a continuous watery discharge from my nose. Okay, so rhinorrhea is a nasal discharge, and along with that the patient will feel a history of nasal obstruction. He will be saying that, doctor sir, my nose is always getting stuffy, I am just doing like this and this. Okay, so there will be a nasal obstruction. Along with that there will be sneezing. Sneezing is continuous. Sneezing is not that a single sneeze. The patient will say that he will be, once he starts, you will be sneezing continuously for 20 or 30 times. Almost those who are watching this video, around 90% of us will have allergic rhinitis, right? So it's not a problem, but we need to know what is the treatment and what all we want to do in managing the allergic rhinitis. So the next one is, there will be, as I said, there will be nasal obstruction, there will be rhinorrhea, there will be sneezing, and the main cardinal feature is there will be itching. The patient will say, it's something itching in the nose. I am just rubbing it again and again. So the patient will have itching in the nose. Along with that, the patient may also say there will be itching in the eyes, itching in the palate region, so itching in the other areas also. These are the cardinal symptoms with the allergic rhinitis is concerned. Okay, so cardinal features. So the patient will have nasal obstruction, which I will repeat again, nasal obstruction, sneezing, there will be rhinorrhea, and there will be itching in the eyes, itching in the palate region. So how are we classifying the allergic rhinitis? We are classifying the allergic rhinitis into two types. One is a seasonal, allergic rhinitis, and other is a perennial allergic rhinitis. Okay, so seasonal allergic rhinitis is present only in certain seasons. Okay, only in certain seasons. Okay, perennial is throughout the year. It is present throughout the year as perennial. Okay, the reason for seasonal allergic rhinitis is there will be certain pollens which are present only in some months. Okay, say in February month there will be a certain pollen, and in October month there will be a different pollen. Pollen is a weed. The trees will produce some pollens, right? That is a pollen. These pollens are aeroallergens. They will circulate in the air and will create an allergic response. Okay, so they are so each pollen has a different season also, and this pollen has a geographical variation also. Some pollens are present right now in Chengalpet, some pollens are present in Delhi, some pollens may be present in Chennai, whatever. Okay, so it's a seasonal allergic rhinitis is present only during that pollen season. Perennial is because of various allergens which I will explain now. Perennial is present throughout the year. Okay, so for your exam they will ask you, define allergic rhinitis. As I said, it is a IgE mediated immunological response of our nasal mucosa to allergens, right? So again, what are the subheadings? So when you write a essay, we want to know how are we proceeding with our paper. The first thing, we will write a definition, and we have classified it to seasonal and perennial, and next we need to write about the etiology and the pathogenesis. Okay, So etiology. What is the main etiology associated with allergic rhinitis? As I said, it is an allergen, right? Allergic rhinitis is because of allergen. So what is allergen? Allergen is a protein. Okay, allergen is a protein which circulates in air, or it can be, because if it's a food allergen, it can be a food protein, but now we are concerned with our allergic rhinitis. So allergic rhinitis is because of allergen, which may be a protein which cannot be visible to us. Okay, and this allergen is now a foreign object to us. Okay, once this allergen enters into our body, our immunity power will push us the allergen out through a sneeze or maybe a itching, whatever. Okay, so the main etiology is so what are we concerned? We are concerned about the aeroallergens. Aeroallergens are the allergens which are circulating in the air. Okay, so every day, every minute we are exposed to some allergens. Okay, sitting in a closed room, we are sitting in an AC, we are exposed to a dust mite. Okay, sitting in a dampened room, we are exposed to fungus. Okay, sitting near a slum area, we are exposed to cockroaches, we are exposed to some other cat dander, something. Sitting in something maybe in a Coimbatore or Pollachi area, or maybe in a Kerala where there is a good ventilation, but there will be a lot of trees which have a lot of pollens which may lead to a allergic reactions. Okay, so aeroallergens can be multiple. As I said, the seasonal allergens will be a pollen. Okay, the pollen is usually a material from the trees or weeds or grasses. Okay, this is usually seasonal, and for ruling out the perennial, we want to rule about dust mite, which is the most common of all. Dust mite is the most common allergen. When you just ask a history from the patient, they will 100% of them will say, I am having a dust allergy. Okay, what the people will think is dust allergy is something like what we sweep, the dust which is present in the environment. Okay, it's a dust mite. It is a dust mite allergy. Okay, it's not a common dust allergy. It's a dust mite allergy. Dust mite is a kind of some insect, which is a kind of insect which is present in our beds, or maybe the mattress, or maybe the pillows. Okay, and every night during midnight, okay, when we sweat, the mite will come up to eat our damaged or the scaly tissues. Okay, and it will just sit on the bed, and when we just roll over, okay, when we just roll over on the materials and we just do like this, we are inhaling the materials from the dust mite, and we are getting allergy. Okay, I will just explain the pathogenesis later also. So dust mite is an insect, not a common dust. Okay, and it is the most common cause for perennial allergy. And the other allergens, as I said, it can be a fungus. Okay, it can be a fungus. Okay, that is we called as a mold, or it can be a cockroach allergy, which is again a more common. The cockroach, the entire body of the cockroach is allergenic. Okay, so then another one, it can be either a cat dander. Some people will say, I am allergic to a cat. Whenever I see a cat or whenever I go near a cat, I sneeze. Okay, it can be a cat dander, or it can be a dog dander, whatever it can be, some animals. Okay, or it can be, as I said, it can be a pollen allergy, and multiple allergens are there. Can be some people will feel some allergen to perfume, some smell allergy. Okay, some chemicals, some irritants. Okay, so these are the various allergens which can produce the allergic rhinitis for us. Okay, so coming on to the and the next most common cause, the genetic. Okay, genetic. Say a parent will come to you asking that, doctor, I am having allergic rhinitis, will my child have allergic rhinitis? Yes, there is a possibility of around 20% chance of allergic rhinitis occurring in children if one parent is positive. Okay, if two parents are positive, the chances will go high, even up to 47 to 50%. Okay, so genetic predisposition is very, very important. So these are the two etiologies. One is a aeroallergen, the other is a genetic predisposition in children. Okay, so coming on to the pathogenesis, which is very, very important. If you draw the pathogenesis well, or if you understand the pathogenesis well, then I will say allergic rhinitis is a cakewalk for you. Okay, so what happens in allergic rhinitis? What happens in allergic rhinitis? Say that whenever we are exposed to that, we are sneezing. It's not like that. Okay, say the first time, say this is our skin. If this is our skin, it may be the skin. Okay, so normally in the skin, or maybe the nasal mucosa, whatever. So when an allergen, say if this is the allergen protein, which is the allergen protein. This allergen protein comes in contact with our skin. Okay, once it comes in contact with the skin, once it enters into the submucosal subcutaneous area, once it enters into the subcutaneous area, it is picked up by the antigen presenting cell. So here there will be a cell which is called as antigen presenting cell, APC, which we call as a dendritic cells, which you will read in the pathology. I am just explaining the pathogenesis here. Okay, so this antigen presenting cell picks up the antigen. Okay, and once it picks up the antigen, it presents to the T helper cell. So it presents to the T helper cell, Th2 cells. So now the antigen presenting cell here will be bound to the T helper cell. Okay, and this antigen presenting cell will be having that allergen with it. So the allergen will be here. Okay, now this T helper cell, with the help of interleukin 4, interleukin 5, interleukin 4, interleukin 5 and TNF alpha, it will present this antigen to B cell. Okay, it presents the antigen. This antigen is being presented with the help of T cells, it presented to the B cell. Once it is presented to the B cell, okay, there will be formation of antibodies. So the antigens are now converted to antibody, and what is the antibody being formed? IgE antibody is formed. Okay, so this is how the IgE antibody is formed. Okay, and now this IgE antibody, what it does, it either goes into the circulation, it's been released into circulation. The IgE antibodies either released in circulation, or if there are certain mast cells here, I am drawing a mast cell, say consider this as a mast cells here. Okay, this IgE antibody goes and sits in the mast cells. Okay, it will go and bound to the mast cells. Okay, these are called as bound mast cells. That is mast cells with the antibody, IgE antibody, which is specific to that allergen present in the mast cells. This mechanism is called as priming sequence. So the first time when I am born, I am exposed to some allergen which is a dust mite. The first time this is priming happens. Okay, priming is the first sequence which happens. Okay, then what happens? Then now the patient is now again the human being or the person is again exposing to that same allergen. Okay, now he is exposed to the same allergen now. After some months, after some days or after some hours, is exposed to the same allergen. Now what happens? Where are the mast cells? The mast cells are present in the subcutaneous layer. They are present everywhere. Okay, so now how will be the reaction is, these antigens are already, there is a presence of antibody in our body. Okay, so now these antigens are directly taken up by the mast cells. So the second time when this antigens, that is allergen is an antigen. Okay, so second time when the allergen or the antigen enters into our body. Okay, so now when it enters into the body, it's going inside the body, these are directly picked up by the antibodies here. Okay, this will go into this will be taken up by the mast cells which are bound with the antibodies, and if these allergens are bound with the same antibodies there, then it will lead to a degranulation of mast cells. There occurs a reaction within the mast cells. The mast cells will have a reaction that is called as a degranulation of mast cells. So now here what happens? The mast cells will be degranulation, that is the mast cells will break up and it will lead to release of some inflammatory mediators, that is called as degranulation of mast cells. Degranulation of mast cells will lead to release of inflammatory mediators. So what happens here? Once the inflammatory mediators come, okay, what are the inflammatory mediators? It may be either a preformed mediators. Preformed mediators are already which are present in our body, or it will be some processed or new mediators. Okay, so preformed mediators are usually the histamine, which is very, very common, the histamine reaction which we all have. Okay, or it can be eosinophil mediated ECF, eosinophilic chemotactic factor, or neutrophilic chemotactic factor NCF, or it can be either a heparin, whatever, of all which the histamine is very important, or it can be a new mediators like what are the new mediators like a prostaglandins, okay, prostaglandins or a leukotrienes like a LT, okay, leukotrienes, or a platelet aggregating factors PAF, okay, or a thromboxane TXA, okay, thromboxane 2, or a tumor necrosis factor TNF alpha. Okay, these are the various inflammatory mediators which you would have come across the inflammation chapter in the Robinson, maybe in Robbins or maybe or some other book in your pathology. Okay, so these inflammatory mediators take its place, take its action. So what happens second time when the patient is exposed to that allergen, same allergen, okay, and the allergen is in high doses, it comes and bounds to the mast cells and leads to degranulation of the mast cells, which leads to release of these mediators in the circulation. So this is how the problem occurs. So once this mediators occurs, what happens? There occurs, so the histamine, what it does? So the histamine causes vasodilatation. Okay, so what happens? The vasodilatation lead to there will be edema of the mucosa. So there will be, once the mucosa or the nasal mucosa or the nasal turbinates are becoming edematous, what happens? The patient will have a there will be the nasal stuffiness or the nasal blockage will be there. The patient will get a nasal blockage. Okay, this will be the first point. And there will be hyperactivity of the glands, hyperactivity of mucosal glands. So once the mucosal glands are hyperactified, okay, what happens? This lead to increased secretions. So the patient is having a rhinorrhea. So before reading our textbook, we need to know how this is happening. That's it. Okay. And one more thing, there may be smooth muscle contraction happening, contraction of the smooth muscle, which may lead to patient having a bronchospasm. In anaphylaxis, the patient may go for a complete bronchospasm and even a complete arrest also. Okay, right. So these are the three main reasons what is happening with the mediators. Okay, I am repeating again, there will be nasal blockage because of the vasodilatation, and there may be increased secretions which may lead to rhinorrhea, and a smooth muscle contraction which may even lead to a bronchospasm. And what are the types of reaction? The types of reaction may be, once this degranulation occurs, there may be a acute phase reaction, which is very common, acute phase reaction. So acute phase reaction, as the name indicates, it is acute. That is, the patient will have symptoms, which is between 5 to 30 minutes of exposure to allergen. Okay, say the patient is exposing to allergen now, second time, immediately you will get this allergic reactions. Okay, that is called as acute phase reaction. Acute phase reaction is within 5 to 30 minutes after exposure to allergen is acute phase reaction, and this is very severe. Okay, the patient now will have all symptoms, like as I said, this is mainly because of histamine inaction. Okay, so as I said, histamine, it causes nasal blockage and it causes sneezing. The patient will have continuous sneezing, there will be rhinorrhea, continuous sneezing. The sneezing will be, it won't be a single sneeze, there will be continuous sneezing, there will be severe rhinorrhea. Okay, and there will be, as I said, there will be edema of the mucosa. So the patient will have a nasal congestion. Along with the mucosa doesn't leave alone with the nose, there may be edema of the lips in anaphylaxis reaction, there may be edema of the lips, edema of the tongue. Okay, and the patient may even get a bronchospasm in the acute phase reaction. Okay, the acute phase reaction is very dangerous, as I am saying now, mainly because of it is histamine. Then comes the late phase reaction. Late phase reaction is because of the other inflammatory mediators whichever I discussed, like a prostaglandins or a leukotrienes or a eosinophils, whatever. Okay, so that is because of the late phase reaction. The late phase reaction, if the patient is getting repeated exposure to allergen again and again, these late phase reaction are usually, they are masked by the early phase reactions. Okay, so late phase reaction, again it produces, there will be the same symptoms, and symptoms will be same, and again the patient is going to have a here the reactions will be presenting after hours after, maybe after 2 to 8 hours after exposure. It's not immediately after exposure of allergen. Say the patient is exposed to allergen in the morning, after 8 hours in the night time he is having some congestion. The symptoms will be the same, there will be a nasal blockage or a nasal congestion. Okay, and there will be rhinitis features, but more of here there will be more of nasal blockage, that is because of the inflammatory mediators there will be more of edema features, that is a nasal blockage or a nasal stuffiness. This will be most common compared to the other. So coming on to our clinical features. So clinical features is what all we discussed till now is the clinical features. As I said, the cardinal features, the patient will have a sneezing, right? The sneezing, as I said, will be a continuous sneeze. The patient will say, my child, or whenever I get up from the bed, I am sneezing continuously for 20 or 30 times, more than 20 or 30 times. Okay, and you will feel that you will feel a tiredness after that continuous sneeze. His body nutrition is going down, you will feel like that. So there will be a sneezing and there will be a nasal obstruction. Okay, if it is an acute case, there will be a nasal okay, it's not acute case. If it is an allergic acute rhinitis, the patient will have a nasal obstruction, and whatever I said in the beginning, there will be itching. Okay, along with that there will be rhinorrhea, which is a watery discharge. Okay, but when it turns into chronic, or apart from that, we need to and when it turns into chronic, when the patient is having allergic rhinitis for prolonged periods of time, maybe for months or maybe for years, the patients will have a ear symptoms, like there will be a ear blockage because of the eustachian tube blockage. The patient is going to have a blockage in the ear. The patient is also going to have a chronic pharyngitis, chronic throat pain. Okay, and even the patient may even have a sleep disturbance also. In the night time, the patient is often getting up from the bed, may also have a sleep disturbance also. So these are the various symptoms the patient may present to you. And in the signs part, the characteristic signs is in our nose, the characteristic sign will be the patient, when we examine the nose, the turbinates will appear somewhat pale and hypertrophied. These are the turbinates. They will appear somewhat okay, the turbinates will be a pale and hypertrophied turbinates. Okay, or one more thing, when you just see the nose of the patient, there will be a picture which is called as allergic salute, which I will show the picture at the end. Allergic salute is nothing but the patient will be keeping on because of continuous scratching of the nose like this. There will be some shining area in this part, or there will be blackening in this center columella area. That is called as allergic salute. Okay, so or sometimes the patient will be keeping on doing like this. There will be some transverse crease occurring in this area. Okay, so these are the various features seen with the allergic signs of the nose. Okay, so there will be allergic salute or transverse crease, and there will be a pale and hypertrophied inferior turbinate may also be seen. Okay, along with that, it doesn't end here. The patient with allergic rhinitis will obviously have ocular symptoms also. So in the eye, what will be the patient is having? In the eye, the patient will be keeping on rubbing his eyes like this. Okay, that will lead to some black mark around the eyes. Okay, when you see his eyes, there will be some blackening around the eyes. That is called as allergic shyness. Okay, so allergic salute, here there are allergic shyness. And one more thing, the patient, there will be edema and congestion of the eyelids. Okay, so the patient will have itching over the eyes, and there will be edema of the lids. And there will be, we can when you examine with the slit lamp, we can even see some papillae kind of some granulation seen along the conjunctiva, along the conjunctiva and sclera. So these are the features of allergic rhinitis and allergic rhinoconjunctivitis, allergic rhinitis along with conjunctivitis. And as I said, it doesn't end here also. It may even present with the allergic pharyngitis, Allergic pharyngitis, how will be like if this is the oropharyngeal area, this is the uvula, this is the tonsillar area. On examination, the pharynx area, there will be presence of some cobblestone appearance in the pharynx. Okay, there will be presence of some granulation. When you see, the patient will be keeping on saying that I am having a sore throat, I am having a sore throat. That is because of the continuous dripping from the nose to the throat. Continuous dripping from the nose to the throat. And when you examine, we can see some granulation along the posterior pharyngeal wall that indicates a cobblestone appearance. Cobblestone appearance of the pharynx. Okay, that may indicate a feature called as granular granular pharyngitis. It's nothing but a feature of granulations. So granular pharyngitis, it is a common sequelae following allergic rhinitis. Okay, and as I said, it doesn't end here also. You need to examine the ear. So what happens? A patient with a continuous nasal obstruction or continuous nasal discharge, the patient's eustachian tube is going to get blocked. Once the eustachian tube is getting blocked, the patient will have features of either a serous otitis media, okay, or sometimes the patient may also may even have features of some suppurative otitis media also, getting ear infection again and again. Okay, so these are the various features of allergic rhinitis, and the allergic rhinitis may also presence with the allergic dermatitis. Dermatitis is not topic here, but allergic dermatitis, again the patient is going to have severe scratching or itching sensation in his body. Okay, everything is correlated. Okay, these are the various symptoms and signs associated with allergic rhinitis is concerned. So in allergic rhinitis, we are classifying the allergic rhinitis based on area guidelines, which indicates a allergic rhinitis and its impact on asthma. As we know, the allergic rhinitis patient will have more of asthma, so this is the guidelines being followed internationally, this allergic rhinitis and its impact on asthma guidelines. What they are classifying is, they are classifying into intermittent and persistent. Okay, intermittent is nothing but less than 4 days a week and less than 4 weeks. The patient was presenting a disease which is less than 4 days a week and it is less than 4 weeks. Okay, persistent is, the patient is presenting with a disease which is more than 4 days a week, okay, and it is more than 4 weeks. So the intermittent is less than 4 days a week and for less than 4 weeks. Persistent is more than 4 days a week and present for more than 4 weeks. Okay, and along with that, we are grading the severity. So how are we grading the severity? We are grading the severity as mild and moderate to severe. Right. So how are we classifying this? So it depends on the allergic rhinitis patient associated. Is there any sleep disturbance with the patient? Is there any sleep disturbance? Okay. Or is there any problem with this daily routine? Okay. Or there is any troublesome in school going activities? Okay. So this is how, if the patient doesn't have any symptoms or any other troublesome symptoms, the patient doesn't have any of these, then he is classified as a mild. The patient has one or more symptoms, then he is classified as either moderate or severe. Moderate to severe. If he has more symptoms, it is classified as severe. If he has one, then it is called as moderate, whatever. Okay. This is what the area guidelines have classified: intermittent, persistent, and based on the symptomatic score, they are classified into mild, moderate, and severe. Okay, so coming on to the investigation. So what all we need to do now for treating the patient? We need to do some investigation. Is the history alone is important, is satisfactory, but we need to classify we need to, and we have classified it into a mild intermittent or a mild persistent or a moderate intermittent or a moderate persistent, whatever. So now we are going to do some investigation. The patient nowadays is not believing a doctor. He will come, he will say that when you write a diagnosis of allergic rhinitis, he will simply turn towards the doctor. Doctor, this is what I said. I am an allergic patient to dust. This is what I said, and you are writing the same prescription, and you are getting some money from me. So what is the use? Then the patient nowadays is keeping on asking like this. So we need to do them some investigation to prove them what allergy they have, or what is their what do we need to do to rectify their symptoms. Okay, so we can either do a routine blood investigation, that is a total count or a differentiate count, but this is not a specific one at all. If you want to do a specific test, we can either do a nasal smear. Nasal smear is nothing but once you take a smear from the nose, take a swab, take a smear from the nose, rub it on a slide, and then check whether there is presence of any eosinophils. So obviously allergic patient will have lot of eosinophilic smear in the nose. Okay, and usually it is done immediately when the patient has the symptoms, and that is either a symptomatic patient. It is done either in a symptomatic patient, or following some allergens we are artificially provoking his nose and following a nasal provocation. Okay, so usually this is not done for all patients, the nasal smear. This is again a research means again a theoretical purpose. The common test and for classifying the allergy or to find out, nowadays the patient will ask me what kind of allergy I have. Doctor sir, please check me what allergy I have. Okay, and for that we have some specific tests like a skin prick test, maybe a prick test, or maybe a scratch test, or maybe a intradermal test, whatever. Intradermal test. Here we are not doing anything in the nose, but what we have idea is there is nothing with the nose here. Okay, if a patient is sensitive to some allergen, say I am sensitized to some dust mite, my entire body is sensitive to dust mite. Okay, since the mast cells are present everywhere, the mast cells in the cutaneous compartment in my forearm is also going to have an allergic component. Okay, so we are doing a skin prick test or a scratch test or some intradermal test. Okay, so what we are doing is, say this is the forearm of the patient. Okay, this is the forearm of the patient. I am just placing a drop of allergen on the patient's body. Okay, I am just placing a drop of allergens. Okay, so say a dust mite or maybe some aero allergens. Okay, and what I am doing is I am just pricking it, or I am just scratching it. Okay, this is called a skin prick test. Say if I am allergic to that allergen, I may develop a wheal and flare reaction over that area. Okay, this is called as skin prick test. And the scratch test is again we are scratching. Intradermal test is we are just pricking it intradermally, whatever. Okay, it's called a skin prick test or sometimes scratch test, whatever. And we will check for the wheal and flare reaction. And we will check, say if I am putting the allergens like and also I will keep some negative values like a saline. I'll just place a drop of saline and scratch it. If see to that there is no false negative reaction. Okay, and I will place a drop of histamine and scratch it. Okay, so histamine should be positive for everyone, saline should be negative for everyone. So these are the positive and negative controls. Okay, so in the skin prick test I can say the patient is sensitized. I am not saying allergic. Okay, the patient is sensitized to which allergen. Okay, so I am placing a cat dander or placing a dust mite, and I am checking, and if there is a wheal and flare reaction happening, then the patient is allergic to that dust mite or that cat dander, whatever. Okay, so this is regarding skin prick test. And there are a lot of other blood investigation like a specific IgE test, specific immunoglobulin E test. Okay, there is a total IgE blood test also we can do, but this is not much important. Specific IgE test is specific to that allergen. Okay, like there is IgE test for fungus like aspergillus. Okay, there is IgE test for dust mite. Okay, so this is a specific IgE test for some various allergens. Okay, a total IgE count can be done, but not much useful. A specific IgE test also not much useful. When this and this skin prick test is the one test which is important. Okay, when these both are combined, that can be a diagnostic one also. Okay, so the next one is RAST. RAST is nothing but a radio allergen sorbent assay, not done for all patients. Okay, say or test done to find out which type of allergen the patient is having. Okay, or we can even do a nasal provocation test. Nasal provocation test is nothing but nasal provocation test. As the name indicates, we are provoking the nose. That means here we are placing the allergen, we are taking the allergen in a toothpick or some tip, okay, and we are placing, or some cotton buds, and we are placing it in the nose, and we are asking the patient to sniff it. Once the patient sniffs the allergen, he will get some acute reactions. There will be acute face reactions occurring. Okay, but this is usually not performed since chances of bronchospasm and asthma are more. Okay, so usually this is denied. Usually this is not done for a routine practice. Okay, it's usually a skin prick test or the specific IgE test or a RAST, radiologist sorbent assay is being done, the routine investigation. So these are the various investigation concerned with the allergic rhinitis is concerned. And we know what are the complications which can come across. What are the complications which we can come across? Allergic rhinitis patient never stops there. He will ask you, doctor sir, if I keep on getting this allergic rhinitis again and again, what can I leave it as such, or what complication will I get? The complications may be what we can explain, that the patient may have a allergic sinusitis. The rhinitis keeps on continuing, it may turn into sinusitis. Okay, or it may even turn into that ear infections, or in the nose it can go into a nasal polyp. What type of polyp? This is allergic nasal polyp is ethmoidal, that is a sinonasal polyp. Okay, or as I said, it can go to the ear, can block the ear, right? The patient have a permanent eustachian tube blockage. The patient can have a chronic pharyngitis. Along with that, the patient may also have a obstructive sleep apnea because of a enlarged turbinate. The patient may also have a obstructive sleep apnea, that is a snoring at night. Okay, these are the various complications the patient may go in for. Okay, and there have been recent studies which indicates that the patient may also have other complications, like the patient may have changes of asthmatic changes, so the lung complication may also increase. So these are the various factors presenting here. Okay, so what is the treatment? Now we have investigated the patient, we have observed the patient with the signs and symptoms. Now what is the treatment what we are going to follow? The treatment protocol considers of three main treatments. Okay, one is a allergen avoidance, which is the best and which is the most important one. Allergen avoidance. So avoid the allergy. Okay, that is, say if I am if I am doing a skin prick test and that comes to be sensitive for my dog, then better don't go near the dog. Okay, or if I am doing a prick test and if it comes to sensitive to some cockroaches, okay, make sure that your plumbing works are clear, no cockroaches nearby. Okay, or if it comes to allergen to some dust mite, okay, make sure that your pillows, the mattresses are being washed regularly and exposed in hot and dry areas. Okay, and there are a lot of preventive measures. These are meant by allergen avoidance. Okay, if you are exposed to some pollens, if you are allergic to some pollens, don't go to parks in that seasonal time. Okay, and don't go to some areas where that pollen is more. Okay, so these are the various allergen avoidance measures. So coming on to the treatment protocol, the medical management, as we know, there are a lot of medical management. The most common, we have an antihistamines. As we know, the oral antihistamines what we usually give, like the first generation antihistamine maybe a CPM or a chlorpheniramine, or maybe a second generation antihistamine like a cetirizine or kind of thing, or maybe a third generation, a newer generation like a levocetirizine. Okay, these are all your pharmacology, which is not much important here. We need to know what is what. Okay, or a fexofenadine, okay, or the new drugs like a ebastin or a bilargic, whatever. Okay, so bilastin group of drugs. So these are the group of antihistamines available. Okay, so this antihistamines, as we know, these will control all the problems, like except the nasal obstruction. It will control the sneezing, rhinorrhea, itching, the nasal congestion, but the amount of nasal obstruction being relieved is less. The nasal obstruction being relieved is less. Okay, the rest all symptoms this oral antihistamine will take care, but as we know, this has side effects like the patient's daily activity is going to be affected because of the patient is going to have a sedation. It has a sedatory side effect, so the patient is going to have a sedation, so he will feel somewhat lethargic in his office activity. He can't drive while taking a first generation antihistamine. Okay, so it has a lot of side effect also. Coming on to the other drugs which can be used here is, we can either prescribe them a sympathomimetic drugs, that is a decongestants. Okay, so decongestants, as we know, there are two groups of drugs, either oral decongestants. Oral decongestants include phenylephrine or a pseudoephedrine. Again, these are pharmacology, whatever I am discussing. So this oral decongestants has a good role in controlling the nasal obstruction, that is the nasal stuffiness, but it has not much role in the sneezing or something. So it has more role in this decongestant. So sympathomimetic drug, it will block the blood supply, it will block the edematic measures, so it will reduce the nasal obstruction. Okay, so these are usually preferred in combination with the oral antihistamines. Okay, or for temporary measures, you can even give the patient a topical sympathomimetic drugs, like a either you can give them oxymetazoline or xylometazoline group of drug, oxymetazoline or a xylometazoline. Okay, these are given for a temporary basis, okay, not for regular basis. If you keep on giving continuously these kinds of drugs, it may lead to a rhinitis medicamentosa. Okay, medicamentosa, this is again an important one for you, rhinitis medicamentosa. So any drug, it should be in a limited amounts, it should not be more. Okay, so this is the second drug what we are giving, but the main drug is a corticosteroids. Corticosteroids, that is a steroids, has a main role in controlling all the 5 symptoms: the itching, the rhinorrhea, the sneezing, okay, the sneezing, nasal obstruction, nasal itching, okay, and nasal discharge and itching in the eyes. Everything is controlled with the corticosteroids. But the corticosteroids, and as I say, the oral corticosteroids are best, but it has very increased side effects. The side effects are more. So what we can do is, the oral corticosteroids are preferred only in acute phase, when the patient is having severe reaction like a bronchospasm or severe any anaphylactic reaction, then you can prefer this oral corticosteroids. If not, you can prefer a topical, that is a intranasal steroids, which is very much beneficial to relieve all the 5 symptoms, again the nasal decongestants, nasal congestion along with this one, and also to prevent this rhinitis medicamentosa. If the patient is getting addicted to this topical decongestant, to prevent him from this rhinitis medicamentosa, you are giving this intranasal steroid again. So this intranasal steroid, there are various groups, like as we know, the fluticasone, again it's a pharmacology, okay, fluticasone or a beclomethasone, okay, or mometasone. These are various groups of steroids which are available for nasal concentration. Okay, nasal concentration. So these groups of drugs can be given for a long period of time, but not continuously. They can be given for a long period of time, and it will relieve all 5 symptoms. Okay, again these intranasal steroids have some side effect. If the patient keeping on using this nasal spray again and again, the patient may even land into some crusting, dryness of the nose. There may be some crusting of the nose, there may be dryness, okay, or there can be sometimes a septal perforation can also occur. Okay, septal perforation can also sometimes occur, or there can be growth of fungal sinusitis can occur if the patient is on prolonged use of nasal corticosteroid nasal sprays. Okay, so these are the various side effects with the intranasal spray, but usually what we will suggest them is use for 1 to 2 weeks, okay, and then leave for some time, and then continue for 2 to 3 months in some episodic usage. Okay, so this is what we usually prefer rather than giving them continuously, but even continuous usage is advisable, but make sure that the patient visits you often for a follow-up. Okay, so coming on to other groups of drugs, either we can give a mast cell stabilizers. So what happens here, what I said, the mast cells is getting degranulated, right? Mast cells, when the allergen comes in contact, the mast cells are getting degranulation, right? So we can use a mast cell stabilizer like a sodium chromoglycate. Again, it has only less role, not much role. Okay, so this can be tried as an addition to one of the antihistamines, but not as a single usage. Again, we can even give a anticholinergics. Anticholinergics are more useful if the patient has allergic rhinitis along with asthma. In allergic rhinitis, it will relieve a nasal obstruction, as we know cholinergic. Anticholinergics, it reduces the nasal obstruction, like ipratropium bromide. Okay, or we can even prefer a group of drug which is a leukotriene receptor antagonist. So leukotriene, again, what it does, it is an inflammatory activity. So just leukotriene receptor antagonist, either a montelukast or a zafirlukast. Okay, these are not given single, these are usually preferred as a combination drug with the leukotrienes, combination drug. Okay, or we can even give them a new generation drug like a anti-IgE antibodies drug, which is right now one drug is called as omalizumab, and there are other drugs in market right now which is about to be launched. Omalizumab, okay, what it does, it prevents the IgE activity, it reduces the IgE activity, so that it is not singly used alone in allergic rhinitis alone, but what it does is it reduces the IgE activity, so it prevents the entry of it prevents the binding of allergens with the IgE. Okay, so omalizumab is given in an injection form, and okay, it is given for a period of cycles. Okay, so this is a anti-IgE it reduces the amount of IgE in circulation. Okay, so these are regarding the medical management. Coming on to other mode of management, so what I said, there are 3 points. One is avoidance, 2 is medical management, 3 is immunotherapy. So immunotherapy, what its name indicates, immunotherapy, again it can be asked as a 2 marks 5 marks for you. So immunotherapy is nothing but it is a, so what I said, allergic rhinitis is a hypersensitivity reaction. Immunotherapy is a hyposensitivity reaction, so it causes hyposensitization of the allergens. Okay, it reduces the sensitization of allergens, hyposensitization of allergens. So what we are giving is, so we are doing a skin prick test, we are finding out whether the patient is sensitized to which allergen, and then we are giving this therapy of this hyposensitizing this immunotherapy for long periods of time. It is not given as a single dose, it is usually continued for months and years, not for months, even for years. Okay, so what it does is it will decrease the IgE activity to that allergen, to that specific allergen. Okay, and it may even increase the IgG activity, immunoglobulin G activity. So what it does is, now our body will think that on changing the immunity, the IgE goes low, our body will think that the allergen is not dangerous. Okay, so once our body think the allergen is a foreign material, then it will push it out like IgE mediated reaction. But right now, when we introduce what we are doing in immunotherapy, we are hyposensitizing, that is, we are introducing the allergen at low doses. At low dose of allergen is being introduced inside our body for long period of time, that is for years, maybe for 1 year, maybe for 3 years, whatever, for long period of time, so that our body thinks that the allergen is not a foreign material, it is a part of our body. Okay, so this is immunotherapy. Okay, so immunotherapy is a gold standard treatment, it's been done for years. Okay, and it's usually not tried in everyone. The patient selection criteria is very important. It is tried for persons who are in whom even after taking tablet, even after taking medications, okay, there is no use, or if the patient is willing for immunotherapy, okay, that is a patient is a good category, that is a young patient, not a young that a middle aged patient, not a old patient and all who is not responsive or not cooperative patient. Okay, so when the patient is not, there is no use with the medication, or if the patient feels that he is taking medications for long period of time, then you may try him on immunotherapy. Okay, so immunotherapy has been done in various modes. Like one is the most commonly done and approved in our country is a subcutaneous immunotherapy. Subcutaneous, in which the allergen is introduced subcutaneously, like our insulin injection. We are injecting the allergen subcutaneously inside our body at weekly interval, or we can increase the dosage at any stage. Okay, and there are other methods like a sublingual immunotherapy, or there can be a nasal immunotherapy, which is being sublingual immunotherapy is being tried. Nasal is still in research work. Okay, so subcutaneous and sublingual is being done, and this immunotherapy will reduce the, as I said, it causes hyposensitization of the allergen. Okay, so that is a gold standard treatment which is being tried. So this is regarding allergic rhinitis is concerned, and in conclusion with the treatment, according to the area guidelines, as I said, if the patient is having a mild disease, the patient is having only a mild disease, which is a intermittent one, mild intermittent, okay, just give him a oral antihistamine, this will be helpful. Okay, if he has nasal block, go ahead with a topical decongestant during that episodes, not regularly. Okay, if the patient is having moderate symptoms, moderate and some or moderate persistent, okay, give him a course of intranasal steroids along with oral antihistamines. Okay, or if the patient is having severe symptoms, okay, give them a course of oral steroids and then reduce it to intranasal steroids. Okay, and you can give either add-on therapy like oral antihistamines, or either sodium chromoglycate or ipratropium bromide as a additional add-on thing. Okay, so this is regarding the treatment compromising the treatment. So I hope this allergic rhinitis chapter will be very useful for you. This can be asked as a essay for you, right, and this will be a viva voce MCQ for you. Okay, and if you do well with the pathogenesis, if you understand the pathogenesis well, it will be very easy. Okay, so I hope you can end the class here. Thank you, and if you have any doubts in this class, you can WhatsApp me in my number. Okay, and I have a Telegram group for the pre-finals, that is ENT for pre-finals next. Okay, or you can join my Facebook page, Dr. Ajay is Exploring ENT. This is my Facebook page. Okay, or you can WhatsApp me in my number if you have any doubts. Okay, thank you.